I have to really confess that toxoplasmosis is so close to my heart. And even now, that proton team with Dr. Rupesh is working on the toxoplasma in full swing. And last week also, one nice article was getting accepted. And we have to really understand the changing concepts in toxoplasmosis. So we need to keep things basic and simple. That is what our motto of the presentation. And if you don't cover the basics, you can get it wrong and the fun will be missing. So we will keep the presentation really ultra basic. So what do you mean by basic? So most of us should know the difference between retinitis and choroiditis. So, starting from color, border of the lesion, plane of the lesion, whether the vessel is going above or below, whether there is a lot of vitritis or not, whether there is an associated subretinal edema, and what are the causes. So, please be pretty clear. Are we dealing with a predominant retinitis or a predominant choroiditis or a combo where one is more common than the other? Okay. So when the patient with retinitis comes in, there is a beautiful algorithm. We can zoom it. It can be focal, multifocal, diffuse, or occlusive. So let us start with the case. This was a 40-year-old male who had a contact with pets, vision of 612. There are some vitreous cells. So what do you feel? Who can just open up? What etiology you will suspect? I do not want you comment and tell me this is toxocell. You just say that there is a predominant retinitis with a sort of vitritis adjacent to that, and there is a vessel also getting involved, probably a chiaralis vasculitis. This could happen in so many differential diagnoses, probably toxoplasmosis. So we ordered a toxo test, IgG, IgM, comes out negative. So doesn't mean that we have ruled out toxoplasma, because serology has to be taken with a pinch of salt. And we did an AZ tab, and again the IgG was 1:60, IgM was negative. PCR again did not support us. What do you do? Start with antitoxo treatment. After treatment, you see the change in the appearance. Okay. So with the change in the appearance, I want you to appreciate the border of the lesion. Border of the lesion is nicely sloping. And if you zoom in there, you can see fine granularity at the borders. So these two are sloping borders and granularity at the borders are considered as treatment response. I mean the positive treatment response. Okay. So even the vitritis is better. Even a child will say that your treatment is working. Moreover, even if the child does not say, the patient will say vision has improved to 6/9. They are able to see better. Got it? So what do? Press the accelerator, add oral steroid at 48 hours. Okay. So the patient goes on for treatment for 8 to 12 weeks. This was one of my true patient who presented on the second month when we started the UVA clinic in the year 2010. Dr. Veena madam sent this child. This patient had a recurrent attack of pan-uveitis and was referred to our beloved retina clinic, and they handled it as endophthalmitis. And they did, as usual, end of uveitis, you treat end of as more important, do multiple times pars plana vitrectomy. Every time you do pars plana vitrectomy, inflammation comes back. So that's why, being a child, Dr. Veena madam referred the patient to me, whether I could make a clean difference in the management of this case. So what I thought was, being a child, I thought, could it be a toxoplasma, and ordered the toxo test. It came out to be positive. And believe me or not, after starting that toxo treatment, this was a fundus picture. So what do you see? Again, there is a lot of scar. At the border of the scar, there is retinitis. And this was our original picture, where you can see a beautiful retinitis as well. So what is the learning from the case? Toxoplasma in children could mimic as endophthalmitis. So we have to be pretty careful The surgeon who did the parsimonious vitrectomy, if he had tried to pay respect and analyze whether there are any retinitis choroiditis, they could have easily picked it up. However, in children, whenever you do vitrectomy, we are super careful not to go close to the retina, and we just do a core vitrectomy, and this so-called retinitis could have been easily overlooked. So be careful to suspect when the toxoplasma can present or masquerade as endophthalmitis. Again, case number 3, a 45-year-old gentleman presented with the recurrent chorioretinitis. Remember, it is chorioretinitis, not the classical retinitis like case number 1. Here, the toxo IgG was positive and IgM was negative. We ordered the Mantoux test, it was 15 mm, still in dilemma of tuberculosis because it is chorioretinitis. CT scan was normal. And you know what? The patient was referred to me like poor response to ATT even at the end of 2 months. So what do? We want to think whether we have to change the diagnosis or not. So we ordered this test called Toxoplasma avidity test, and this was a picture. You can see a beautiful scar also. The pattern of the scar is little different. It is, if it is tuberculous, you know that it will be paravascular, close to the vessels, which our colleagues at other centers will agree. And we started the anti-toxo treatment. You can see the change in the treatment response. The diagnosis is written on the face. If you pay respect to the vessels, you can see the beautiful chiaralis vasculitis also. Of course, chiaralis is not specific for toxoplasma alone. It can happen in TB or any other type of uveitis. What I want to convey to you is response to treatment speaks 1,000 powerful words than any of the investigations and any of the articles speaks to us. So response to treatment is a supremo. Okay, keep that in mind. So when atypical, these 2 tests have really helped me in the last 15 years to order this toxoplasma avidity test and the PCR test for toxoplasma. Of course, in this patient, as you can see, the toxoplasma nested PCR was positive. So FFA, even though it is chorioretinitis, there was a reason to suspect toxoplasma and go for further investigation as PCR. Again, the key to learning is we have to invert the problem. So this I did not say, this Jacobic, there is a big volume of books in our library, Albert Jacobic. He said that whenever you want to learn ophthalmology easily, you have to invert the problem. All my students will know that I keep telling in each other class, invert, 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 always invert. So when toxo can masquerade as uveitis, the reverse is also possible. TB can fool us as toxoplasma. Tell me the scenario. See, this was a patient who was given the ATT with oral steroids. After oral steroids, you see the beautiful response to treatment. So looking at the first picture, you will be thinking that predominantly it is a retinochoroiditis. Why not consider toxoplasma? However, when you put these things in perspective with the history of contact and of course the Mantoux test and the imaging perspective, you will make a clear sense of whether to start ATT with steroids. As I said earlier, response to treatment speaks again more than 1,000 powerful words here. Pustular. Toxoplasma can also masquerade as acute retinal necrosis. The trick to differentiate is again the OCT. OCT has become like a histopathology slide to look at the layers of the retina that are getting involved. As you see here, there is an inner retinal hyperreflectivity with the shadowing of the outer retina and choroid. And this was the article which nicely elaborates on the diagnostic dilemmas in retinitis and endophthalmitis, where you can learn a lot of information how to differentiate toxoplasma from ARN, from tuberculosis, from endophthalmitis. So there are a lot of variants of PORT. PORT stands for peripheral outer retinal toxoplasmosis. Why is it called variant? Because classically the anterior layer of retina is getting involved and vitritis is minimal. Hence, defective vision occurs more in this variant rather than floaters at presentation. So we can easily catch even from the symptom of the patient that floaters is very, very minimal and defective vision is more predominant in this PORT. So this is a picture of PORT. See, as you can see, this can antedate the classical toxoplasma, if not properly identified with the proper OCT and careful fundus photography. When you don't properly pick the PORT, at due course of time, you can even get into a classical full-blown toxoplasmosis. So toxoplasma retinitis can also masquerade as ARN, especially in the immunosuppressed. Last week, we had an immunosuppressed patient bilateral ARN was the initial diagnosis. Peripheral, there was a lot of retinitis. After reading this article, I doubtedly ordered this toxoplasma test. Surprisingly, the test came out positive. Even the treatment with intravitreal Gancevor was advised in the EMR, and you have to cancel it out and go in for intravitreal clindamycin. We are waiting for the response to treatment. Sometimes ARN could also masquerade as toxoplasma, and especially in an immunosuppressed patient. So these are the very, very peculiar toxoplasma findings, combine retinal artery and venous occlusions. So pay respect to the perivascular lesion around the vessel occlusion. If you see some retinitis and funny looking appearance of the vessels, please pay respect and order an OCT. See, are you suspecting a additional retinitis or choroiditis? So toxoplasma in AIDS is entirely different because it is multifocal. And classic toxoplasma is monofocal. Here it is multifocal. Multiple satellite lesions you will see, and later they can coalesce and go to the center. And the important thing looking at the picture is the vitritis will be very, very less because the body is not able to mount an immune response. Vitritis will be sparse. More importantly, it can be bilateral. Bilateral multifocal retinitis, vitritis less common. You specifically order for HIV Tridart. Of course, the HIV Tridart can fool us if the patient is in the window period. Pay attention and ask all the history of exposure as well. You'll ask me, what the hell are you going to do after making a diagnosis that the patient is immunosuppressed? Is the treatment anyway different? Yes, the treatment is going to be different. You will not give a lot of dosage of steroids in an immunosuppressed patient. Point number one. Point number two, if there is an ocular involvement in toxoplasma in an immunosuppressed, it's a straightforward indication for you to order for brain MRI, brain CT scan, because ocular toxoplasma antedates the brain toxoplasma. So in an immunosuppressed patient, if you are going to identify that it is toxoplasma, you will save the life of the patient to prevent the brain toxoplasma. So the treatment for toxoplasma in AIDS is going to be lifelong because it is not going to respond so easily like the classical immunocompetent toxoplasma. Hope these two take-home messages makes a mark in your mind. So toxoplasma can also present as neuroretinitis, and in a classical neuroretinitis, if you see carefully adjacent to that, there is a retinitis with subtle hemorrhages around. So most often this is acquired rather than a reactivated infection. And I have to thank Dr. Manohar Babu sir. How can we forget Dr. Manohar Babu when we speak about toxoplasma? He is the first one who identified this acquired toxoplasma occurring as an epidemic. So he was consultant at Pondicherry, Coimbatore, Aravind, before he shifted to Salem. He happened to see a collection of cases, more than 300 cases throughout the world. If you type an epidemic of toxoplasma, the name of Dr. Manohar Babu and our Aravind publication will come. So no other ophthalmologist has published more than Dr. Manohar's case in a single case series. Ultimately, he has to go into non-academic responsibilities. He shifted gears. However, his insights from the epidemic of toxoplasma is this acquired toxoplasma is super common than the classical toxoplasma which happens at the end of the scar. So we have to keep that in our mind. What are the other atypical presentation? There are endless. Toxo can happen with REG-RD, serous RD, optic neuropathy, choroidal ischemia, vasculitis, RP-like presentation, neuroretinitis. But this was unique. Scleritis presenting as a manifestation of toxoplasmosis. There is no retinitis, but just scleritis. This was presented by one of our UVF fellow when I was working at Madurai, scleritis as a manifestation of toxoplasma without retinitis. So be very careful that sometime there are atypical presentation as well. So what are we going to do? As a clinician, what are you going to do? We are going to think for these two dimensions, serological tests and imaging tests. Serology, we know all these things. Toxo test, IgGM, Sabin-Filben is academic interest. PCR is really a troubleshooter. And Goldman-Whitmer, again academic. And of course, there are miscellaneous tests as well. Imaging, OCT, B-scan, autofluorescence, and FFA are going to be really, really helpful. The OCT findings in toxoplasma really fascinated us in the last few years. So you're going to put the raster. I'm sorry that to put this big flowchart, which is published in our newsletter, courtesy to our Narayan Nethralaya Dr. Padma Malini, who's elegantly characterized how to differentiate based on the OCT, toxoplasma from ARN, from CME, from endophthalmitis, from the epidemic retinitis, more importantly, where you have an inner retinal involvement, whereas toxoplasma and the ARN will have a full thickness involvement. Most importantly, choroidal involvement will be there in the toxoplasma. Okay, so we will see all this in the subsequent slides. As you see in HIV, this is a characteristic multifocal presentation. Put the raster properly, classic toxoplasma. As you see in this slide, what you see is an untreated toxoplasma. How do you say untreated? Because there is a lot of vitritis and the VR interface, there is a lot of characteristic exudates, and you can see that a lot of active inflammation going on. Okay, choroidal elevation is also important to look for. So when in doubt of ARN versus toxoplasma, these pointers are all going to be helpful. Yes, as you see, there is a tissue loss, the full thickness retinal involvement in ARN. As we highlighted earlier in the diagnostic dilemma article, the fungal endophthalmitis, there will be choroidal involvement, but there will be outer retinal involvement. So this is again going to be helpful in fungus versus toxoplasma. Predominantly inner retinal, as I said, think of post-fever retinitis, like your rickettsial infections, predominantly inner retinal involvement. The TB, again, there will be choroidal, more of chorioretinal rather than a retinochoroidal involvement. The beauty happens in the treatment response. Again, the third time I'm repeating, response to treatment speaks 1,000 powerful words. Here, the resolution pattern heals with pigmentation, with the centripetal clearing in toxoplasma, whereas in other, it is exactly opposite to that. The centripetal clearing is going to be really, really handy to put our ship on correct directions. It is a magnetic compass for all of us. These are the typical OCT findings, and we are able to identify the newer novel optical coherence tomogram findings, like as you see, this stalagmite deposits, detached hyaloid, intraretinal edema fluid. These were all identified by the PGI team. Those of you who are interested, go to the Uveitis Society of India website, and in the edition of newsletter 2019, Toxoplasma is there. You can download it. There's wonderful articles written by the original researchers who have identified all these OCT findings and all this literature review. So what are the treatment recommendations? What are we going to do? The lot has changed from time immemorial. The prophylaxis, pregnancy, what drug you are going to give, what drug you are not going to give. I will not go into it. From a practical standpoint of view, when do you give intravitreal? Clindamycin is 1 mg plus 400 microgram of dexamethasone may be effective as triple therapy was a conclusion from the recent randomized control trial. It's not useful in immunosuppressed patient. Keep that in mind. The patient is immunosuppressed, intravitreal alone will not really make sense. So of course, IVTA or intravitreal should not be given in toxoplasmosis. Yes, as I said that comparing oral versus IVCD, there are the Sohelian trial where they compared this and found that the intravitreal is as good as the oral, and the take-home message from the study was whenever the IgM is negative, your intravitreal is going to work really well. When IgM is negative, intravitreal is going to respond well. And when the IgM is positive, your classical therapy is going to work really well. Of course, it's convenient. The side effect will be much lesser. Pregnant and pediatric patients, good to take. Cons, see, toxo is a systemic disease. If you are going to handle a systemic disease with a local therapy, you are violating the protocol. So you have to even combine the intravitreal therapy with the systemic therapy. Keep that in mind. So there are, whenever in UVA sessions, there will be a lot of, controversy sessions, debate sessions. The classical debate is oral versus intravitreal toxotherapy. In a local disease, you can give a local treatment. When there is a systemic disease, it makes sense to combine local with systemic rather than fighting one is better than the other. So how to prevent recurrent toxoplasma? We have prophylaxis like trimethoprim, sulfamethoxazole are available, and half the dose is recommended. And these colleagues from Brazil have done even long-term trials till 3 years, 6 years, and found that when the patient is on prophylaxis, you know that toxo is an endemic disease and it has a propensity to create epidemics. So whenever the disease is endemic, treatment is going to be different. Why? Because if the disease is non-endemic, you are good to give a monofocal therapy or a single drug therapy. If it is an endemic disease, you are always good to combine two drugs. This I learned from attending one of the international conferences. Most of the clinicians around are giving a single drug therapy for Toxoplasmosis. But being an endemic disease, it's always good to combine with two drugs. You will agree with me if I say that I will give INH treatment for TB. It doesn't make sense. Even you will combine with a triple drug therapy for the intensive phase and go on for a two drug therapy. The idea is to prevent development of resistance and for the efficacy of the treatment. So these are the basics which we need to keep in our mind. Okay. So these are some lovely flowcharts. Those of you who are interested can go and look into it. But what I want you to focus really on is the sensitivity of the PCR is really, really good in the immunocompromised patient than on the immunocompetent patient. So when in doubt, and the patient is suspected to be immunosuppressed, either by HIV or diabetic or any other means, you are good to look into for exploring the variables of PCR. So maybe I suggest that the immunocompetent versus immunosuppressed variable also should be incorporated into several other infectious uveitis like tuberculosis as well. So there are a lot of recent developments like AI, this classification criteria, SUN2 has come, Standardized Uveitis Nomenclature 2, which was published in the year 2021. And they have classified the Toxoplasma retinitis as focal or paucifocal necrotizing retinitis, evidence with PCR or IgM antibodies, classical ocular phenotypes, excluding certain other things. So these are the things which we need to keep in mind. Things are changing. Gone are the days of SUN1. SUN2 is out. So maybe after some time, even SUN3 or so many other sun will come. And those sun has to make our life easy and interesting. Okay, so how can I forget this flowchart? So this is a wonderful flowchart I picked up from the Shankar Nethralaya website, where they studied the morphology. How can you exclude non-infectious causes of retinitis? Okay, so based on outer retina, inner retina involvement, full thickness, white-rich retinitis, you can identify whether it is candida or toxoplasma or epidemic retinitis. It's nicely picked up in this article. Masquerades of retinitis. So not all retinitis are toxoplasma. Okay, not all choroiditis is tuberculosis. So you all know that sometime when you pay respect, attention, you could see some aneurysms that can masquerade as retinitis. Again, non-infectious causes could be so many other things like azure, cancer-associated retinopathy, Behçet's. Behçet's is known to cause a transient retinitis. Migratory retinitis is one question you can expect later in the quiz session. It happens in Toxocara. The retinitis keeps moving from one domain to another domain. So not all retinitis means is toxoplasma. Keep your mind open. don't, as we get zoomed up in a specialty, we get so close to the tree and forget sight of the forest. So don't be hyper zoomed up, zoom out. When we zoom out, we get a better clarity and better perspective. Thank you so much.